L3-4. Sir, I'm going to give you an injection. Do you remember anything about your original surgery?
Yep.
All right. I'm going to give you some numbing medicine. You've got a great anesthesiologist this time, okay? So she's done a few of these with me and she's very good. All right, so you're going to feel a little stick and burn, and then things will start numbing up. If you get pain at any time, just say ouch, okay?
Okay.
But try not to move your body, all right?
Okay.
All right, that's my hand on your back. I'm just feeling your anatomy, feeling around, trying to figure out where to start. Now I know where to go. Okay? Little stick, I told you. Little burning, just relax, everything's okay. So the injection of numbing medicine, unfortunately, is uncomfortable. Does Emla cream really work? Emla cream? It does, right? But it just takes a while to settle in. We should put some on in pre-op. Let's, who's going to be responsible for getting that ordered? Will you tell Ann, please? I want to get some Emla cream. I want to try it, see if it works. You know, about half the patients are uncomfortable from the injection. So it'd be nice if they didn't have that discomfort. Yeah? Yeah, but I need a sterile. I don't think that's sterile. Yeah, but the Emla cream doesn't work on the surface. It goes down and penetrates. So by putting it on in pre-op, I think we could, then by the time we get here, we can do sterile prep and drape. All right, just let me know if there's some discomfort, okay?
Okay.
Just say ouch, but don't try to move your body. All right, yeah, I'm just giving you more numbing medicine. I apologize. Shot. All right, so far so good. I apologize. Just give that a second to work. Try to relax. So we're treating L3-4. He has an annular tear. His pain is localized to 3-4. Oh, she's over there? Yeah, this is a good one for you. Let's go lateral, please. Now, it's kind of hard to tell which disc you're at from an AP, which is anterior posterior view. That's what we were just looking at. You really need a lateral view to really know what level you're at. Okay. Yeah. So not bad. We're headed to the right level, but when you look at an x-ray for navigation and localization, you really don't want to cut out the sacrum, which is what you're looking for in the lumbar spine to navigate. So let's go a little bit south just to capture the full sacrum. Make sure we're not missing something. Good. Sacrum looks good. 5-1, 4-5, 3-4. All right, I think you can go north about half an inch with your base. Take a shot. You're pulsing. I'd go a little more north, just a little bit, maybe half an inch more. Good. Let's see it. Lock the base. Lock your base down. Now, you're going to need a little wag. You see the pedicles there of 3? They're offset, so you want to, just about a degree, you want to figure out which way. I don't know which way, but you want to figure it out. So the pedicles of 4 are perfect, but the pedicles of 3 are off, which means either we have parallax or we have scoliosis, one or the other. All right, let me have the wag, please. I'll figure it out. Okay, shot. So that's worse. Shot. That's perfect. Lock it in. So you need to get the pedicles of the space above and below. Now we lost the sacrum. So let's release your wag again. We're going to need to go north a little bit. Lock it. Now bring your base south. Shot. Let's see where we are. I need to see the sacrum. Bring it south. Shot. All right, that's too far. But you know what? Let's see. Let me wag it. Release your wag. Shot. Perfect. Lock it up. So now we see the sacrum at the bottom. We know what level we're at. So that's 5, 4, 3. We're going for 3, 4. Now this 3-4 herniation is small. based on the old MRI. It's not a big herniation. It's small. But small herniations can cause big pain if they're in the right place. So I never use the size of the herniation to judge whether it's going to cause a lot of pain. Just think about a person. If you were to meet a really big guy, right, and he doesn't know how to fight, and you have to fight him, he's not going to cause much pain because you're going to beat him. But he's really big, but he fights like shit. On the other hand, you can meet a little guy, or women, not trying to be sexist, and they will kick your butt and cause a lot of pain. So just because of their skill, right? So you can't use size to judge. Sorry about that. And when it comes to herniations, you can't use size to judge either, because it is completely misleading. That's one thing I can tell you, very important. But a lot of doctors, sorry, don't understand that. They think the bigger the herniation, the more pain it causes, and it's completely untrue. And that's why, unfortunately, there's a lot of people living in pain, Sean, because their doctors don't take them serious. They look at the herniation and go, that thing's tiny. That can't be causing that much pain. But actually, it is. Sean? How's blood pressure? Let's get it down. Yeah. Shot? Everything's good, sir. We just want to get your blood pressure down a little. Let me know if you feel any discomfort. Shot? All right, so I'm a little higher than I want to be. I'm going to try to reposition. Shot? You doing all right? Shot? Hate to do it, but I think I need to just restart a little bit lateral. Shot? So the reason I did that is because, shot, I'm not happy with the way that the needle was interacting with the facet joint. Shot. I could feel the facet joint pushing me superior, up, basically. You okay? Shot. Is that okay, or is it uncomfortable? Just try to lay still. Shot. Did you watch your first surgery? Shot. All right. So, shot. That it? You sure? I don't think it registered an image.
We have a question.
Yeah, just give me a second. Yes, shot. Sorry about that, sir. We're almost done, I promise. Shot. Do you normally take pain medication? Did you take it today? But you took everything you normally take, or do you take something else too? Oh, but you stopped the ibuprofen. Interesting. So he's a little pain sensitive, more than I would expect, but I think I remember him being that way from the first surgery. So he's had the laser surgery at the bottom discs before, and now we're fixing the one that we never fixed before. All right. Shot? Yeah, that's perfect. All right, let's get an AP. Yes, I'll take the question, Sean. So we're going to have you asleep in just a few minutes, okay?
So the viewer on Periscope is wondering, if this patient's already had DLDR before, why do they need it again?
Great question. So this patient had the DLDR at L4-5 and L5-S1. Those are the discs, perfect. Those are the discs that we're not treating today. So they had two obvious herniations, L4-5, L5-S1. L3-4 was a tiny little tear, and it didn't look like that's where his pain was, and it wasn't localized to that area. It was further down in his back. So we fixed the 4-5 and the 5-1, and his pain went away at 4-5 and 5-1. However, he then either right away, I don't know, how long did it take for you to get pain up here? Was it right away or did it take some time?
It was pretty much right away.
Yeah, no, I needed to hear him, so it's okay. So when you had the first DLDR at 4551 and you were walking around that next day, did you have the same pain you're having now? Was it there or did it take some time to come? Took a while for it to come. Like what, a few weeks, a month? A few weeks. All right. So basically, this is the part of the treatment that before you get to surgery, figuring out where the pain comes from. And I did a good job. I figured out his pain was from 4551. We treated that. It got better. But then he developed pain at 3-4. He didn't have that pain at 3-4 before his first surgery, which was 8 months ago. Yeah, about 8 months ago. So his first surgery 8 months ago, he had pain at 4551. We fixed those discs with a laser. His pain went away. He didn't have any pain until a few weeks or months later. Then he started developing pain at 3-4. We went back and looked at his MRI, and sure enough, he had a tear there, but it was super small. And this is where that small tears cause big pain comes in. And he didn't have that pain originally, but then he developed it. So basically, once we got rid of the pain at 4551, the pain was now coming from 3-4. Yeah. So that does happen. It's not common, but it does happen. All right. So he injured his back. He injured 3 discs, 3-4, 4-5, 5-1. 4-5 and 5-1 looked terrible on the MRI. 3-4 looked barely noticeable. And his pain, again, was localized lower. That's why we did the lower surgery, and it worked. But now he's developing pain at 3-4, which he didn't have before. That's really in a nutshell. Is that the pain you get? Yeah. All right. So that's amazing. That is the pain he typically gets. How bad was it on a scale of 1 to 10? 10 being the worst pain. Shot. How high did it go? 8? And that's where you typically get the pain now? All right. We're going to put you to sleep. When you wake up, we'll be done. All right. Can you count out loud? Go ahead. Good job. Count to 100. Okay, fascinating. Keep going. You're doing phenomenal. Let's turn that off for a second because it's so loud. Keep going. You're doing fantastic. Let me know when he's asleep, please. So we're putting the patient to sleep with propofol. Remember, he has an unsecured airway. We're not putting him out completely. We're just putting him in the gray, kind of sleepy, but still his airway is secure. If you put somebody to sleep too deep, then they stop breathing. You put their breathing centers to sleep. We don't want his breathing centers going to sleep. He'll stop breathing. They become, huh? He's good? Damn, you're fast. So this is why this is exciting. Look at that discogram. There's like, if there's a tear, it's microscopic. I can't even see it. It's below the threshold of being detected by the fluoro. Most doctors would look at this disc and say there's nothing wrong with this disc. It looks cotton ball. It's called cotton ball when the dye in the middle of the disc looks like a cotton ball. This is basically a diagnosis of what's called internal disc disruption. It's basically an inflammatory process just inside, deep inside the annulus where the tear is. Remember, I looked at his MRI almost a year ago, and I thought there was a tiny little abnormality at 3-4. Tiny, I mean millimeter. And I thought, nope, that's probably not causing his pain. Plus, the pain is lower at 4551, clearly at 4551. So we treated 4551, pain went away, and then a few months later, he developed pain at 3-4. Now we image it, and you can see there is a little bit of dye outlining the disc herniation. You all see that? In the back of the disc, there's like a bow. a little bit of dye. It's so faint it looks like a ghost. Well, that dye is leaking out through a tiny microscopic tear in the annulus. So the other thing that's very important is that this patient has an exceptionally low threshold to pain. And that's probably why that tiny little tear is causing so much discomfort that he's going to come and have surgery for this. What we've already established from the injection is that this disc is the cause of his pain. We asked him, is that your typical pain? He said yes. So it's concordant. And it was an 8 out of 10, which is shocking considering that the discogram is so normal looking. I would never normally, in most people, that kind of a discogram with that kind of an architecture of the disc would not cause such severe pain. So, you know, he really does. Everybody has different pain thresholds for acute pain, and his threshold is low. In other words, he's very sensitive to pain, which, you know, is that an evolutionary advantage, Shot, or is that an evolutionary disadvantage? Is that a more developed cortex of brain, a cerebral cortex? I mean, if you think about it, primary somatosensory cortex is a newer part of the brain. It's in the part of the brain that's new. New as in, you know, a few 100,000 years, maybe a few million years, but not old like is in, you know, tens of millions or billions of years, right? You understand what I'm saying? So it's in what's called the neocortex, neo being new cortex, new part of the brain, as opposed to being in the archicortex, like the cerebellum. The cerebellum is an old brain structure. The cerebral cortex is a new brain structure. His pain responses are coming from the cerebral cortex, or newer parts of the brain, still evolving. So the fact that his pain threshold is so low, that he's so sensitive to pain, even though he's taking his regular pain meds, except for ibuprofen, that's amazing to me. You don't see a lot of patients like this. It's not a bad thing. I mean, it is bad in the sense that for him, that little sources of pain cause a lot of aggravation and suffering. But it's not a bad thing. It's just him. It's like hair color, eye color, skin color, you know, all those physical attributes of people. You know, it's just part of their genetic makeup of who they are. So I'm not trying to say anything bad about him. Trust me, I'm just fascinated that such a small damage to the disc could cause so much pain. He's so sensitive to it. Okay? Guys are always being criticized for not being sensitive enough, right? And here's a patient who's sensitive. So it's good. I mean, it's good. I'm sad that he's suffering, but on the same token, it's quite fascinating. So the tip of this dilator is almost at the bulging disc shadow. And I'm really happy with the x-ray pictures of the navigation because you know, it was a perfect navigation. All right, getting a little bit of bleeding from the epidural space. I'm not able to advance the dilator with my hands, even though I'm twisting and pushing, so I'm going to have to use the mallet. People get freaked out when I use this thing. You can see the tip of the dilator is pushing into the herniation now, or bulge I should call it. It really is a bulge, but a bulge is a herniation. All right, Shot. Yeah. All right. This is going to be the more stimulating part. He's responding, isn't he? Is he responding? He's responding, right? Isn't that amazing? Such a normal looking disc. Literally, so few people would think this disc was the cause of the patient's pain. I can't even tell you. If you took this image and showed it to spine surgeons worldwide, pain management doctors worldwide, and asked them, what's the chance it's this disc is the cause of the patient's pain? They would, 99.99999% of them would say no. It's too small. Now, did I say that? No. Because when the patient came back to me and complained of pain above his old pain, I knew that it was L3-4. And I knew it was that little tear there that we could see pre-op. Again, he didn't have it after his first surgery. All the pain went away. But it came within a few months of being active, increasing his activities. So, why is that? Because when you get a little tear like that, a lot of times it heals, but then you become more active, and that tear that was, and when I say heal, I mean partially healed. It partially healed. You know, annular tears that have nuclear material wedged inside the annular tear, they never fully heal because they can't. To fully heal, you need to form scar tissue across the annular tear in the same thickness and consistency. And scar tissue, by the way, is type 1 collagen, which is the same thing the annulus is made up of, with some elastin and some fibrin. So basically, let's see what we got. That's our latest. That should be good enough. What I'm trying to say to you is, the disc can't heal properly if there's a herniation there, a small one, even a small one. So what I do is I go in there and clean out that, what's called the interposed nuclear material, which is the nuclear pulsus, the jelly that's wedged inside the annular tear. By the way, Tiger Woods just had another back surgery. For those of you who don't know, he's his 5th back surgery. He had 4 back surgeries on one disc. Basically, he lost $1 billion worth of income over however many years that was. And of course, his golf game went to hell, but he was in pain all the time. If he would have come to Deuk Spine Institute, we would have fixed that disc the first time. One surgery. I can't call him up. That's the problem. I don't know his phone number. So the sad thing is that I literally would have fixed him with this surgery the first time, and he wouldn't be back with adjacent segment disease now after a 5th surgery at the Texas Back Institute. Problem is, the Texas Back Institute doesn't know this technology. Where is my irrigation? Well, I know it's there, but I need it here. This looks like the inside of a jelly donut. Let's go. It's not flowing. I had it open. It wasn't coming, so I played with it. All right. But it's not, that's not restricting it, no. All right. We're good. We're good. Hold on a second. Let me get this focus. Hold on. I'm having trouble for some reason focusing it.
Hey, can we show you, yeah, you can bring more. I don't know, are you watching the top one or?
Oh, I was watching the bottom.
The bottom? Yeah, you can bring it, please. You know, go on. Can you help? Yeah, in that case you don't need to move the entire thing.
Don't move anything yet. Give me 1 second. It's weird. Is the focus working? I think it is. That's probably good. All right. So that blue stain stuff is nuclear material that's degenerated. So clearly has been exposed to the effects of inflammation. So that's another very important point for those of you who come after me to do these procedures. Look at this stuff. It's all broken up. This is the nucleus pulposus, and it's stained deep blue. The deep blue stain is not normal. Normal nucleus pulposus does not stain blue. The only reason this stuff stains blue is because it's damaged. And how could it possibly be damaged when it's in the middle of the disc? The answer is simple. The tear in the disc that he has, a small tear, has allowed inflammation to travel to the center, to this part of the disc, pretty much not the center, but close to it, and caused basically inflammation and swelling, because the nucleus pulposus is very inflammatory. It's pro-inflammatory. It means it stimulates inflammation. Okay? And so you've got this very pro-inflammatory material in the center of the disc called the nucleus pulposus, and it's hidden from your body's inflammatory system because there's no blood supply to the nucleus pulposus normally, unless you get an annular tear. Then you get a blood supply to it. So the annular tear allows the growth of blood vessels. Look at all the scar tissue here, from the outside of the disc down towards the center of the disc. So blood vessels grow from a vascularized region of the disc, which is the outer half of the annulus normally, to the middle of the annulus or center or inner fibers of the annulus, and hence potentially the nucleus pulposus, if the process is allowed to, which it can. There's nothing to stop it. So it's the inflammation tracking down along the tear to the nuclear material. That is the cause of pain in the disc. You can see the annulus fibrosis here. I'm working on it, trying to clean it up. It's got a lot of scar tissue in it. You see the nuclear material, the little pieces of disc herniation. They should normally be as one big white stuck down mass, like a marble in there. And they're not. They're actually in fragments. So this disc was fragmented when it was probably originally injured into fragments. And some of those fragments are squeezing out through that tiny little tear in the annulus. Look at this. This is all scar tissue here. This is not normal annulus. So I'm inside the annulus fibrosis right now. This whole thick thing is annulus fibrosis, but this is not normal annular fibers. The organization of this material is not normal. It looks to me like thick wads of scar tissue from chronic inflammation. It doesn't look like the nice annulus that I normally see, which is individual or semi-individual clusters of fibers. Like, look at those pieces just coming out, herniation. It's quite an interesting, this is not normal, normally what we see. Normally we see big annular tears that are not healed. They're full of inflammation. This is a mostly healed annular tear with a little bit of residual non-healed where the inflammation is occurring. And that's where the patient's pain is coming from. He had 8 out of 10 pain from this disc, which is amazing because the architecture on the MRI, the architecture on the discogram, the architecture on the X-ray, it all looks pretty much normal and literally would be overlooked by 99.99999% of doctors who are in the field of spine and spine care, because they just wouldn't realize that such a small structural abnormality could cause such massive pain and discomfort. Literally, we're the only place in the world that would identify this and treat it. So, people out there suffering with chronic back pain that have been told surgery is not necessary, treatment is not necessary, there's nothing wrong, it's all in your head. Don't believe those doctors. They're lying to you. As a matter of fact, they're not lying because they're trying to lie to you. They're lying because they're completely ignorant of the truth. That'd be like the old days. The old days when they used to tell the captains of ships, don't sail too far because you'll fall right off the earth. The earth is flat and your boat will literally go over the edge and you'll die. You'll never come back. And they actually believed that. People believed it with ferocity, with conviction. And then, of course, they discovered the world was actually round and you won't fall off the edge of the earth. And people still believed the earth was flat for a long time. And the earth was round people were laughed at, ridiculed, actually burned at the stake, hung, mutilated, tortured. But in the end, it turned out the earth really is round. So shame on those people who held on to a belief that was wrong, even though when somebody introduces something new, you really should critically assess it and do an assessment and find proof one way or the other. Either it works or it doesn't work. So this surgery works for back pain. It's amazing. Neck pain, thoracic pain. We just started doing thoracic disc herniations in 2020. Last year, for the first time, I did 6 patients. Each patient had 100% relief of their pain after the surgery. And we did them all safely. Stand by. I don't like that schmutz on the end. Let's wipe it. Okay. So I've been doing cervical and lumbar Deuk laser disc repair for many years, 15, 16 years now. But thoracic, I never did because it's more dangerous, and also because there's very few patients with thoracic disc herniations that need surgery. Most of them are asymptomatic. But we found 6 patients that, were suffering from pain from their thoracic disc herniations. Some of them had radicular symptoms as well, going around the side to the ribs. Others didn't. They just had axial pain. We did their surgeries. By the way, they actually paid cash for their surgeries, as most people do. And very happy, very satisfied with the results. All the testimonials you watch of Deuk laser disc repair patients, about 95% of them pay out of pocket a lot of money for the surgery. Relatively a lot of money for the surgery. And yet they're all very happy with the pain relief. So these aren't patients that we paid for their testimonials. These are patients that paid me for surgery so we could get their surgery done. And yet they still have great results that they do testimonials for the rest of you all to learn and watch and have hope that there's a way to fix your problem. All right, just about done. This is that little tear right there. You can see a little blue. And it's partially healed. There's some calcium from calcification or bone spur formation, basically. I'm just cleaning up the last of the tear. I'll be done in 3 minutes. And we're going to go check on our first patient, the lady from Texas. She is just about ready to go home. Those of you that watched, we did a L3-4, L4-5, L5S1 Deuk laser disc repair. And she's doing fantastic, I think. Let's go see how she's doing. We'll meet you over there. We're going to wrap this up. Do we have any questions, Sean?
We do not.
Great. So, my viewers know everything there is to know. I love it. I'm going to wrap this up in about 2 minutes, and we're going to head over to the recovery room and check on our first patient. How would you like that, huh? Sean, do we have our system set up to walk it over yet with Sunny and the Wi-Fi?
I don't think so yet.
What do you guys wait, for me to always have to circle back? I'm glad I got a few laughs. For those of you who don't know about Circle Back, the new President Biden's press secretary, she's famous for saying, "I have no clue, I'll circle back." And so we're all just making fun of her. All right, wow, look at the tear right there. That's amazing. It's that's why the dye wasn't coming out. There's some jelly right there, some nuclear material. So just about done. It's the last stretch. You can see the blue right there wedged inside the tear. That's nucleus pulposus. When he originally injured his back, it was there. It just wasn't symptomatic until he started getting more active. And then once he got more active, this tear became painful and inflamed and then started causing pain for him. So, all right, that looks good. The cavity is removed. It's good, it's good. Done. Laser off. All right. Well, ask your questions now, or I guess we can ask them next week. Scope off, laser off. I'm going to put a little happy, little steroid in there.
Yes. Excellent. Thank you very much. Thank you.
So let's show the audience this incision here. Oh, I love the system. How it works is just so amazing. The Germans really do design things quite well and manufacture things quite well. I was a little disappointed, I was talking to a Siemens rep. Siemens makes medical imaging products like MRIs, and Siemens has jumped on board the programmed obsolescence bandwagon, which is, the iPhone, right? How they program it to basically after a year or two, it doesn't have all the latest features. You got to buy a new one, basically. So it's programmed in. So now the MRIs they're selling for $1 million, in 5 years they're obsolete, and they have a new one out. And basically they stop manufacturing the parts to repair them. Literally stop manufacturing parts, repair them. So you're forced to buy a new MRI.
Wasn't that the old slogan for the Whirlpool repairman, that their stuff didn't wear out?
Yes. That used to be an American ideology, is that things that we bought were manufactured to last. Now things that we buy are manufactured to be outdated in 5 years or less. And it's only for one reason. Not that the materials themselves rust or break down. It's because they want to sell more. It's disgusting. And so we're trying to be green, and yet if the President Biden wants to be green, then force manufacturers to get rid of programmed obsolescence. Force manufacturers to manufacture things that last. Okay. Yep. All right. Maybe you agree, maybe you don't. So here's the incision, folks. That is 7 millimeters. It's tiny. The whole disc repair was done with that tiny incision. This patient will go home in about 45 minutes, and I expect this pain to be 100% gone. Great case. Very educational. Yeah, very interesting case. I looked at that MRI at 3-4, and I'm thinking, are we supposed to be here for that? But that's because I didn't realize we already fixed 4551. So, all right, EBO, 1 drop. No complications. Left DLDR. All right, Sean, you want to meet me in the recovery? Let's shut this stream down since there's no questions, and let's go check on our first case. Thanks, everyone.